Welcome to Roadmap to Residency. Hello, everyone. I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We are currently in our hematology part. We will be running through some questions with you guys to help you on your journey to a 250. So let's get started. So, which of the following is the most likely cause of this patient's pain? A 31-year-old woman comes to the office due to a 4-month history of left hip and groin pain. She has a constant dull achy pain at rest that is exacerbated by the movement of the hip or weight bearing. The patient has had no recent falls or other trauma. Medical history is significant for sickle cell disease, pneumococcal pneumonia, and acute chest syndrome. There is no redness, warmth, or tenderness over the hip joint, but decreased active and passive internal and external rotation. Extension and abduction are noted. Imaging of the hip is found in the exhibit. And which of the following is the most likely cause of this patient's pain? So here you can see this is the X-ray that is given, and here may be something abnormality. So what do you think the abnormality is? So the question is asking us about that, what is the cause of this patient's pain? So it may be due to the absence of cartilage in the epiphyseal plate, cytokine-mediated increased bone resorption, cytokine-mediated new bone formation, necrosis of bone and marrow cells, synovial pannus formation. So pause the video and think what is the answer. So the patient is suffering from osteonecrosis or avascular necrosis. So it may be due to the thrombotic or embolic occlusion. So, for example, in case of sickle cell disease, or it may be due to the consumption of glucocorticoids, maybe in case of vascular inflammation or injury, excessive alcohol use, and traumatic fracture. The clinical manifestations include maybe pain on weight bearing and decreased range of motion. On gross inspection, there may be weight-shaped or geographical zone of necrosis. The articular cartilage is viable but may be distorted or detached from underlying bone. The microscopic inspection may show dead bony trabeculae with empty lacunae, necrosis of surrounding adipocytes. The avascular necrosis of femoral head. So this one here is the intrauterine device. Here is the collapse and the sclerosis of the left femoral head. So the femoral head have gone into avascular necrosis. And this one is the right femoral head that is normal. They generally do not ask you about the histology of osteonecrosis, but in case they ask you, we have to be prepared. So this is the histology. Here you can see the necrotic marrow fat cells, and these are the dead bones here with empty osteocyte lacunae. So this patient has a chronic hip pain that is worse with weight bearing and decreased range of motion in multiple axes. X-ray reveals flattening and patchy sclerosis of the femoral head consistent with osteonecrosis. Biopsy is not generally required for diagnosis, but microscopic analysis of the affected bone may show dead bony trabeculae and fat necrosis. The osteonecrosis occurs due to the disruption of macrovasculature of the bone, and the femoral head is the most common location, although other bones may be affected. The conditions associated with osteonecrosis include the following. Sickle cell disease can cause thrombotic occlusion of arteries. The embolic disorders like fat emboli or decompression sickness can directly occlude the small arteries. The high dose systemic corticosteroids and excessive alcohol intake can cause fat embolism and adipocyte hypertrophy in the marrow. The vasculitis, example, in case of SLE, systemic lupus erythematosus, can injure the vessel wall, resulting in distal ischemia. Femoral neck fracture can disrupt the medial circumflex femoral artery, which is the main arterial supply of the femoral head. So let's talk about sickle cell disease, because in my classes, in my videos, we don't only just talk about the questions and move on. We also dive deeper into all the high-yield concepts that may be tested from that particular topic. So let's talk about sickle cell disease. So the sickle cells look like something like this and may be seen in case of sickle cell anemia. The sickling occurs with low oxygen conditions, example, high altitude, acidosis, and high HbS concentration, that is dehydration. The sickle cell anemia is the autosomal recessive disorder resulting from the inheritance of two HbS genes, homozygous, causing normal HbA to be replaced by the mutant HbS. Now, HbS is distinguished from HbA by its substitution of an uncharged valine for a negatively charged glutamic acid at the 6th position of the beta chain. The under reduced oxygen conditions, example acidosis, hypoxia, changes in the temperature, dehydration, and infection. under reduced oxygen conditions, the SBS molecules polymerize and causes the RBCs to sickle. And the sickle RBCs obstruct the small vessels, leading to ischemia. So these normal RBCs will just get sickled in this shape and under some conditions like hypoxia, acidosis, and these sickle cells can just disturb or just can block the small vessels, leading to ischemia and leading to the osteonecrosis, for example, in our patient. The sickle cell trait. So it results from the inheritance of only one SBS gene. That is, these individuals are called heterozygous. So 1 in 12 people of African descent are the carriers, but it may also occur in Italian, Greek, and Saudi Arabian descent. So the patient with sickle cell trait are not anemic and have a normal life expectancy. And the sickle cell trait is associated with isothenuria, which is the inability to concentrate or dilute urine. Patients will have a constant osmolality on urine analysis testing. So this one is very high yield point that is there in case of sickle cell trait. So screening can identify asymptomatic individuals with sickle cell trait for whom genetic counseling may be provided. So almost every organ can be involved in case of sickle cell disease. So the blood can involve, leading to chronic hemolytic anemia and aplastic crisis. In heart, there can be high output congestive heart failure due to anemia, CNS, stroke. In GI tract, there may be gallbladder disease or stones, splenic infections and abdominal crisis, painful crisis, osteomyelitis, and avascular necrosis. Lungs, there may be infections and acute chest syndrome. In kidneys, there may be hematuria, papillary necrosis, and renal failure. In eyes, there may be proliferative retinopathy or retinal infarcts. In genitalia, there may be priapism. Now let's talk about some of the clinical features of the sickle cell disease. So there may be manifestations of chronic hemolytic anemia like pallor or jaundice. There may be some pigmented gallstones, delayed growth and maturation, especially in case of boys, and high output heart failure. So the manifestations of acute vaso-occlusion, which is very, very important in case of sickle cell disease, and the questions are generally presented in the case of, in the format of acute vaso-occlusion. The pain crisis, which are the most common clinical manifestation. The vaso-occlusion results in the bone infarction causing severe pain. The bone pain usually involves multiple sites and may or may not be bilateral. The pain is self-limiting and usually lasts 2 to 7 days. And there is something called as hand-foot syndrome or dactylitis, which is the painful swelling of the dorsa of the hands and feet seen in infancy and early childhood. And it is often the first manifestation of sickle cell disease, which is caused by the avascular necrosis of the metacarpal and metatarsal bones. Acute chest syndrome is something like the clinical presentation similar to pneumonia, characterized by the chest pain, respiratory distress, pulmonary infiltrates, and hypoxia. It may be due to the repeated episodes of pulmonary infections. Splenic infection, that is due to the recurrent episodes, eventually lead to autosplenectomy, whereby the spleen is reduced to small and calcified remnant. The spleen is large in childhood, but is no longer palpable by 4 years of age. Priapism, erection due to vaso-occlusion, usually lasting between 30 minutes and 3 hours, usually subsides spontaneously after the urine is passed, after light exercise, or after a cold shower. A trial of hydralazine, nifedipine, or antiandrogens may prevent further episodes. And there is something called a sustained priapism, which is rare but is a medical emergency when it lasts for more than 3 hours. It can also affect kidneys, leading to the renal papillary necrosis, and it's characterized by the hematuria. There may be stroke, primarily in children, myocardial infarction, and avascular necrosis of the joints. Manifestations of chronic vaso-occlusion may include chronic lower extremity ulcers, ophthalmologic complications, and chronic pain. Aplastic crisis may occur, which is usually provoked by a viral infection such as human parvovirus B19, which reduces the ability of the bone marrow to compensate for chronic hemolysis. There may be infectious complications like functional anemia, which results in increased susceptibility to infections, like particularly encapsulated bacteria such as Haemophilus influenzae and Streptococcus pneumoniae. There may be predisposition to Salmonella osteomyelitis, or which can lead to encapsulated organism. This can be due to encapsulated organism. So the treatment of sickle cell disease generally to prevent the crisis first. So we need to avoid the high altitudes, maintain fluid intake, and treat infections promptly, because this all can predispose the sickling process. We need to prevent the infections by early vaccination of pneumonia, Haemophilus influenzae, and Neisseria meningitis. The prophylactic penicillin for children is less than 5 years of age. We may prescribe hydroxyurea which may be indicated for adults with severe symptomatic sickle cell disease and frequent pain crisis. So it enhances the hemoglobin F levels, which reduces the sickling. The management of anemia may be due to the by the folic acid supplementation or blood transfusion. The management of pain crisis is by the hydration and morphine, and the ultimate resort is bone marrow transplantation. Now let's move on to the topic thalassemias. So there are generally two types of thalassemias, alpha and beta thalassemia. So whenever there is excess beta chains, okay, then that means that the patient is suffering from alpha thalassemia. Alpha chains are missing, so there will be excess beta chain production in response to that. Whenever the beta chains are missing, there will be excess alpha chains production, and that is called as beta thalassemia. So alpha thalassemia occurs in chromosome number 16 and due to the deletion sort of genetic errors, and beta thalassemia occurs in chromosome number 11 and it is generally due to the mutation sort of genetic error. So we can just skim through all this. Okay, this I have just kept it for your revision. If you want, we can just pause the video and go through all this. So thalassemia may be alpha or beta. So alpha thalassemia, so 4 genes are involved in making the alpha hemoglobin chain. So alpha thalassemia major is when there are 3 mutated genes, okay, or maybe there are 4 mutated genes. So if there is only 3, then there may be moderate to severe manifestations, and if there is 4 mutated genes, which is usually rare, so it can occur, it can lead to usually early death. So if there is only 1 or 2 mutated genes, then if there is 1 mutated gene, the patient is called as a carrier of thalassemia. And if it is 2, it is called as alpha thalassemia trait. And these are generally mild or asymptomatic diseases. When we talk about beta thalassemia, so 2 genes are involved in making the beta hemoglobin chain. So beta thalassemia major and beta thalassemia minor. So 2 mutated genes, it can lead to Cooley anemia or mild to moderate manifestations. And if there is only 1, then it will lead to mild manifestations. Now let's talk about hemoglobin electrophoresis. So during gel electrophoresis, the hemoglobin migrates from a negatively charged cathode from here towards the positively charged anode here. Now HbA migrates the farthest, followed by HbF, okay, which is followed by HbS, which is the sickle cell trait, and which is followed by HbC, okay, HbC here, okay, then CCC. So these electrophoresis, you have to look at the electrophoresis of different diseases, okay? But generally they only ask you about the sickle cell diseases. So you can just remember that in the sickle cell disease here, it just follows the HbF. So this is because the missense mutations in the HbS and HbC replace the glutamic acid negative with valine neutral and lysine positive, which is respectively making the HbC and HbS more positively charged than HbA. So the positive will just repel and will just push it toward the cathode side. So let's do one more question. So what is the most likely diagnosis for this patient's condition? A 25-year-old woman of Mediterranean descent presents with fatigue and mild jaundice. Lab tests revealed microcytic anemia with an elevated total iron binding capacity and a normal serum ferritin level. Hemoglobin electrophoresis demonstrates an increased level of HbA2. Genetic testing confirms a homozygous mutation in the beta globin gene. So yeah, you know the answer by now. Options are iron deficiency anemia, sickle cell anemia, thalassemia major, beta thalassemia, or hereditary spherocytosis. So the patient is suffering from beta thalassemia. The patient has symptoms of fatigue and mild jaundice. In lab, there is a microcytic anemia, elevated total iron binding capacity, and normal serum ferritin level. The hemoglobin electrophoresis may show increased level of A2 on hemoglobin electrophoresis, which is characteristic of beta thalassemia. In beta thalassemia, there is a decrease in the synthesis of beta globin chains, leading to an increase in the production of other types of hemoglobin, including HbA2. The genetic testing confirms of a homozygous mutation in beta globin gene supports the diagnosis of beta thalassemia. Thank you for watching. Keep studying hard.